Good afternoon, one and all. I feel very privileged to be a part in celebrating Digital Week by connecting 52 medical colleges to improve the healthcare system. Myself, Merli Chima, teaching faculty, College of Nursing, SGPGIMS, Lucknow. So today my topic is cardiac dysrhythmias. So this cardiac dysrhythmias, it is an important aspect which the nurses and medical people must know to recognize the abnormalities of any rhythm or rate in the ECG pattern. So the normal cardiac system, or the normal conductive system of the heart must be very well known by the medical people as well as including the nurses. So first let me tell about the general view about the conductive system of the heart. These cardiac cells have peculiar four properties which other cells do not have. They are automaticity, excitability, conductivity and contractibility. Because of these four peculiar properties of the cardiac muscles, these do the normal conductive system. So here we consider this SA node as a pacemaker of the heart, where the fires or the electric stimuli gets originated, and through the intra-atrial fiber that we called Bachmann's bundle, the impulses are being transmitted to the atrium for the contraction, and then from the SA node that impulses transmitted to the intranodal tracts to the AV nodes, and next AV node, bundle of his that we called common bundle, and bundle branches that divides into two, right bundle and left bundle, and last one Purkinje fibers. So this I have made as a diagrammatic way. That is, first one is here that SA node, and from SA node that impulses are being transmitted to the atrial muscles, that is intra-atrial fibers, and next one is through the AV node, and then from there it comes to the bundle of his and Purkinje fibers, and again the next impulses will start. So here already I have mentioned here. So next, what is NSR? Normal sinus rhythm. When we say that when we see the ECG strip, we say mostly it will be written as a NSR. It refers to a rhythm that starts in the SA node at a rate of 60 to 100 times per minute and follows the normal conduction pathway. When the rate is between 60 to 100 and it follows this normal sequence of conduction, then we say that as a NSR. So if there is any problem with this normal conduction pathway along with the abnormal fluctuation in the rate, then we say that as a cardiac dysrhythmias. So what is cardiac dysrhythmias? These are a problem with the rate or rhythm of heartbeat caused by changes in the heart's normal sequence of electric impulses. Next we'll see what may be the causes for getting this dysrhythmias. There are two conditions, two etiological factors we could say. One is cardiac condition and another one is non-cardiac condition. Cardiac conditions, mostly all the cardiac diseases become a reason for getting cardiac dysrhythmias. That first one is if any defect in the accessory pathways, that what are the conductive system tracks we mentioned now, that will be one of the reason. And cardiomyopathy, myocardial infarction or coronary heart diseases also we can include here. Valvular disorders, conduction defects and heart failure. So these are the things will comes under cardiac condition which leads to cardiac dysrhythmias. And when you see the non-cardiac conditions, acid-base balances, alcohol, caffeine, tobacco, and some of the medications can cause dysrhythmias, like digoxin toxicity and some other medications like CNS suppressant medications, electric shock, hypoxia, metabolic conditions, sepsis, shock, and electrolyte imbalances. Under electrolyte imbalances, mostly like hyperkalemia, hypokalemia, and hypomagnesemia and hypercalcemia. These all of the electrolytes plays an important role in the normal rhythmic action of the activity of the heart. Next, we'll move into the types of dysrhythmias. There are different types of dysrhythmias we could mention here, like atrial dysrhythmias and ventricular dysrhythmias. So first one is, let me discuss about sinus bradycardia. So what is sinus bradycardia? That is the general terminology like we study from the basic, that is when the heart rate is lesser than 60 per minute, but the origination of the beat will be from the SA node, and the impulses follow the normal pathway through the conduction system, and here that rhythm will be the shape and rhythmic activity will be normal. That means P and QRS complexes have normal duration and pattern. Only thing that rate will be lesser than 60 per minute, that we say sinus bradycardia. And the clinical association, what are the etiological factors? Already I have mentioned the common etiology factors for dysrhythmias. So when you see only for bradycardia, increased vagal stimulation, that will become the one of the main source of getting bradycardia, and it may be considered as a normal parameter in athletic and those who are having healthy young adults. And other medical conditions which causes bradycardia, anorexia, atherosclerotic heart condition, hypoendocrine states, when the metabolic conditions are decreases, that will causes the suppression or the decreased depolarization of the cardiac cells, that may result in bradycardia, hypothermia, and increased intracranial pressure. So when the increased intracranial pressure, that will causes the fluctuation in the stimulation of the baroreceptors, so that may lead to increases the parasympathetic, so increases the sympathetic parasympathetic, so that may lead to bradycardia. And myocardial infarction also can be associated with this bradycardia. And some of the medication which could lead to bradycardia, antihypertensives, beta blockers, calcium channel blockers, and CNS and digoxin are the responsible factors for bradycardia. And what are the symptoms of bradycardia? As we all know, once the heart is not able to pump properly, or when the rate is getting sluggish or slow, definitely the cardiac output may get decreases. So due to low cardiac output, what are the symptoms the patient could, we could observe in the patient, and the patient can tell they are lightedness or dizziness, easy fatigability, syncopic attack, and dyspnea, and chest pain and confusion. Even to the brain also the blood flow may get decreases, so patient may go into confusion, and sometimes the altered sensorium also can occur in bradycardia. And how to manage this? So the main aim in this is to increase the heart rate, so the cardiac output may get increases. So the medications which helps to increase the heart rate are atropine, isoproterenol, dopamine, and the stimulation of the sympathetic nervous system. Like we can expose the patient into the situation where the fight and flight response to be activated more. Such situation should be exposed, so the heart rate may get increases. And what are the etiology? We saw that medications which causes bradycardia, that should be withheld or avoided. And the permanent treatment for this sinus bradycardia is permanent pacemaker implantation. Next, sinus tachycardia. So the same way, like only thing the rate will get increases, that is from 101 to 200 beats per minute. Other than that, the rhythm and the shape, duration and the pattern, everything will be same like a normal sinus rhythm. The conduction pathway is the same in sinus tachycardia as that in normal sinus rhythm. The sinus rate is 101 to 200 beats per minute. The discharge rate from the SA node increases because of vagal inhibition or sympathetic stimulation. Because of that overstimulation of the sympathetic or the inhibition of vagal maneuver, it will lead to tachycardia. The clinical associations are excessive consumption of caffeine and lifestyle, unhealthy practice of lifestyle like smoking, nicotine intake, and medical conditions, anemia, hemorrhage, fever, hypotension, pain, shock, hypothyroidism. So these all medical condition will lead to increases, because in anemia, hemorrhage, everything, the oxygen carrying capacity or that blood supply to the heart will get decreases. So the oxygen demand of the body is not fulfilled by the oxygen availability in the body. So the heart will pump very fast in order to compensate or in order to meet the oxygen demand of the body. So the heart rate will get increases. And medications such as epinephrine, atropine, that also can lead to, like as a side effects of this medication, when you administer this medication for treating bradycardia, that could adversely lead to tachycardia also. And myocardial damages and hypoglycemia, psychological stress could lead to sinus tachycardia. So what are the significance, are the symptoms? Even here also, because of this faster rate, that effective contraction or the force of the myocardial contractility not taking place, so that could lead to decreased cardiac output, chest pressure and pain, dyspnea, characteristics fluttering in the chest, dizziness, syncope, and the increased heart rate can occur. Treatment. First, we need to identify the cause or etiological clinical association which lead to tachycardia, and if we find that stress or pain is the cause for getting tachycardia, effective management for pain should be given, and stress is there, like a management of stress reducing management should be applied to the patient to reduce the stress, and relaxation techniques we can incorporate into the patient, and the medications also can be given, calcium channel blockers, digoxin, beta blockers, anti-anxiety agents, adenosine. So these all are the medication will helps in the relaxation of the blood vessels, so the blood flow to the heart will get increases, so the forceability or the contraction may get increased, the heart rate may get decreases. And carotid massage or vagal maneuver should be given. And if clinically unstable patient, that is if the patient goes into unconscious or the pulse rate is unstable, then definitely we could go for synchronized cardioversion. So we'll see carotid massage here. Before doing carotid massage, we must be ensure that there should not be any carotid root or carotid stenosis, and the place should be identified, that is the exact location for doing carotid massage is inferior to the angle of the mandible at the level of thyroid cartilage, and 10 to 15 seconds the firm pressure should be applied to the area, so the vagal inhibition or the sympathetic activity will get suppressed, the parasympathetic will get stimulated, so the heart rate can be reduced. And next one is premature atrial contraction, PAC. It is a contraction starting from an ectopic focus in the atrium and coming sooner than the next expected sinus beat. So here ectopic focus anywhere from the atrium. Usually that normal in NSR or the normal conductive system we saw that the SA node is the automaticity area where the or electric impulses originates. Here in premature atrial contraction, here the other than SA node or the ectopic area, the stimulation gets started, that is before getting the normal sinus beat. So that we call the premature atrial contraction. Here P wave, the normal pattern or normal duration of P wave will not be get here. Distorted P wave will be observed in PAC. And etiology, what are the etiological factors? Already I have mentioned cardiac diseases, COPD, CAD, valvular heart disease, hyperthyroidism, and caffeine, electrolyte disease, disturbances, anxiety and unhealthy lifestyle. These are the causes for getting PAC. And treatment, if the PAC count is less than 6 per minute, there is no specific treatment required. And if it is extra, like more than 6 per minute, if we observe in the ECG strip, then the treatment is required. And the etiological, based on the etiological factor, the causes should be ruled out first. Here caffeine consumption, exception of caffeine consumption and stress will lead to in PAC. So that caffeine consumption should be reduced and stress also should be reduced. And other medications like anti-anxiety agents, beta blockers, calcium channel blockers should be given to the patient. And next one is PSVT, paroxysmal supraventricular tachycardia. It is a dysrhythmia starting in an ectopic focus anywhere above the bifurcation of the bundle of hairs. It is seen in Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome, that is a syndrome. Here, extra electric pathway will be created in the heart, that is Wolff-Parkinson-White syndrome. Mostly this PSVT we can observe in Wolff-Parkinson-White syndrome. And the common etiological factors when you see emotional stress, overexertion, cor pulmonale, CAD, RH3 digitalis toxicity. And in here it is a rapid rhythm. See here, paroxysmal, we are saying that meaning paroxysmal, that is a sudden onset. So this picture we could see that is in a normal sinus rhythm strip, the PSVT will develop in a acute or the abrupt onset. It is a rapid rhythm that starts and stops very suddenly, and for accurate interpretation, the beginning and end of the PSVT must be seen, and sometimes we call this as a paroxysmal atrial tachycardia also. Here the rhythm will be very regular, and the rate may get vary from after the normal sinus rhythm, the rate will get increases, that is 150 to 250 beats per minute. And sometimes here the P wave will be buried in preceding T waves, and it will be difficult to see, and the PR intervals are very difficult to measure here, and QRS complex QRS interval may be normal, and sometimes it may get delay or widened QRS if the conduction may get a delay, or it can be very rarely we could see in like a QRS widen. Usually the QRS pattern and duration will be observed most probably normal in PSVT. Treatment, vagal maneuver should be given, and IV adenosine. This is also one kind of fifth class antiarrhythmic medication. Anti-beta adrenergic blockers and CCB calcium channel blockers can be given, and RFCA, that is radio frequency catheter ablation. Mainly this radio frequency catheter ablation is indicated in case of where there is the extra firing or the tachycardia cases. This radio frequency catheter ablation will be done. In this, the electrical energy is used to burn or ablate the areas of conductive system as definitive treatment of tachydysrhythmias. Whether the heart is beating very faster, there the radio frequency catheter ablation will be very effective as a definitive treatment. And next one, atrial flutter. It is an atrial tachydysrhythmias. There are two atrial tachydysrhythmias, are the atrial flutter and another one is atrial fibrillation. In atrial flutter, here we could see regular sawtooth shaped flutter waves that originates from single ectopic focus in the right atrium. The ectopic pacer fires at a rate of 200 to 350 beats per minute. Regular sawtooth shaped flutter, because here that ectopic focus, ectopic origin of fires are there, but single ectopic foci. But in atrial fibrillation, we can, like next slides we'll see, in atrial fibrillation, there are multiple ectopic foci, so there is abnormal P waves. Here that P wave will be regular, and the shape and duration will be regular and uniform as it develops from or originates from the single ectopic focus. It is associated with coronary heart diseases, rheumatic heart disease, hypertension, cardiomyopathy, pulmonary embolism, hypothyroidism, etc. And sometimes patient may be asymptomatic also, and some patient may be presented with some symptoms like palpitations. See, this second one is atrial flutter. Here that P waves are regular, and it is a regular pattern as it develops from single foci. Here atrial fibrillation, see here that P waves are irregular and different shapes. In each beat, the P waves are different, and the pattern also will be distorted waves, because here that ectopic focus, multi-ectopic foci in atrial fibrillation, that is the major difference in atrial fibrillation and atrial flutter. Treatment, warfarin is given to prevent stroke in a patient with atrial fibrillation, because when the atrial flutter, and the stroke is the most common high risk or the preventable complication, we can say. Once we observe the patient goes into atrial fibrillation, the blood clots can get easily, so that should be treated by anticoagulant therapy, and anti-dysrhythmic drugs should be used to convert flutter to sinus rhythm. Mainly here we are giving amiodarone, the anti-dysrhythmic drug, to convert the flutter into sinus rhythm, and other medications also can be given to convert into normal sinus rhythm, and cardioversions also can be used if the patient doesn't respond to the medications, and if the atrial flutter is persisting for a longer period, then cardioversion can be the definitive treatment to convert the flutter into the normal sinus rhythm. And radiofrequency catheter ablation also can be done, that is electrophysiological study can be done to ablate or to burn or to remove the excessive firing cells from the heart. Next one is atrial fibrillation. It is characterized by a total disorganization of atrial electrical activity because of multiple ectopic foci, resulting in loss of effective atrial contraction. In atrial flutter, there we saw that single ectopic foci, so the P waves are regular duration, regular pattern, so there that atrial contraction will be effective when compared to atrial fibrillation. But in atrial fibrillation, because of this multiple ectopic foci, the effective atrial contraction will not be there, so the just quivering or the just shaking of the atrium will take place, so more chances of getting clot formation in atrial fibrillation. So anticoagulation therapy is very much important in atrial fibrillation. Several ectopic foci causing the atria to quiver rather than contract. Atrial rate will be 350 to 600 beats per minute. Risk factors of atrial fibrillation, all the risk factors already I have mentioned. The common like age factor, one of the risk factor, and diabetes, all the comorbidities and obesity, inactivity, all unhealthy practices of lifestyle will be the one risk factor for getting this dysrhythmias. When the ventricular rate is between 60 to 100 beats per minute, it is atrial fibrillation with the controlled ventricular response, we say. And only if the ventricular response, QRS complex is between 60 to 100 within the controlled range, then we say that is a atrial fibrillation with the controlled ventricular response. And if the ventricular response greater than 100 beats per minute, then we say that is a atrial fibrillation with the uncontrolled ventricular response. Treatment. Sorry. There are three goals in this treatment. First one is, if it is under the controlled ventricular response, then nothing to be done to decrease the ventricular response. Only thing that tachycardia, that fibrillation should be corrected, and the supportive other medication should be given. And if we observe this second one, that is, if the ventricular response greater than 100 beats per minute, then our goal should be the priority we must give to decrease the ventricular response. And the ventricular response can be decreased by the medications called calcium channel blockers and beta adrenergic blockers can be given to reduce the ventricular response. And to prevent stroke, anticoagulant with warfarin should be given. And this anticoagulant is indicated if the atrial fibrillation observed longer than 48 hours, then anticoagulant should be given. And if we provide cardioversion before, just 3 to 4 weeks before cardioversion, as well as even after cardioversion also, for some period anticoagulant treatment should be continued. And anti-dysrhythmic drug should be given, amiodarone. Here this is mainly to convert the atrial fibrillation into the normal sinus rhythm. And electrical cardioversion, if the medication doesn't work in reducing the fibrillation into normal sinus rhythm, then electrical cardioversion must be given to reduce or to correct the abnormal tachydysrhythmias into normal sinus rhythm. Here radio frequency catheter ablation MACE procedure can be done. Surgical procedure it is, and it stops atrial fibrillation by interrupting the ectopic electrical signals that are responsible for dysrhythmias. Here the incision will be made in both atria, so the abnormal or the ectopic firing where the ectopic focus we could observe, that can be removed out. That is surgical procedure called MACE procedure. And cryoablation also can be done, cold therapy. It is used to stop the formation and conduction of these signals and is restore normal sinus rhythm. And next one is heart blocks, atrioventricular blocks. So far we have dealt with atrial dysrhythmias. So atrial dysrhythmias, sinus tachycardia, sinus bradycardia, and PAC and PSVT, and last one we saw that atrial flutter and fibrillation. And next one, atrioventricular heart blocks. See here, it is abnormal delay. What is AV heart blocks? There is a delay in conduction of impulses from the atrium to the ventricles. That is AV heart blocks. Usually patients will be asymptomatic here. And there are three types of heart blocks are the first degree, second degree, under second degree, Mobitz 1 and 2, and last one is third degree. So first one is first degree heart block. Here, when we say that is a first degree heart block, if we observe the delay in the SA node producing prolonged PR interval that is more than greater than 0.2, then we say that is a first degree, that normal PR interval that is 0.12 to 0.2. So when the interval is observed to be greater than 0.2, and that we say first degree AV block. Here the heart rate will be normal and the rhythm is regular, and usually patient will be asymptomatic here and not serious also, but initially if we ignore or neglect, it can be a sign of higher degree of AV block. So soon after detecting as a first degree, the proper management should be given, hence the further complication or further progress into the degree of AV block can be prevented. And the etiological factors for AV block, all cardiac diseases, and what are the etiology I mentioned in general cardiac dysrhythmias causes, that only here also I am mentioning. And second one is second degree heart block. Here there are two types, a type 1 that we called Mobitz 1 or Beckybach heart block. It is a progressive lengthening of the PR interval until a QRS complex is dropped or not conducted, usually asymptomatic, and the treatment may be none or sometimes the the rate, if we observe lesser rate, so atropine can be given in order to increases the heartbeat, and temporary pacemaker can be helpful here. And in first degree, see here, the delay in the like a PR interval will get delay, and until one QRS complex is dropped out or missed, that PR interval will be dragged or prolonged. That is the first type, Mobitz 1. That is a progressive lengthening of the PR interval until QRS complex is dropped or not conducted. And second degree type 2 or Mobitz type 2, we say every second, third or fourth sinus impulse is blocked and may have 2, 3, 4 P's to each QRS. That means like 2, 3, 4 P waves will be continuously occurs, and after every P wave there should be a one QRS complex that will be dropped out or mixed here. So in first degree, that means not in first degree, second degree Mobitz 1, we saw that one QRS will be dropped out, missed. And in second degree or Mobitz 2, here many QRS complex may missed or dropped out of QRS. So only we could observe P wave 2, 3 P waves can be observed here. And more serious, it is aggressive management is needed to prevent progression into complete heart block. Due to block in one of the bundle branch, certain impulses from the SA node are not conducted to the ventricles. So the common treatment, pacemaker should be placed, atropine and dopamine for severe hypotension, because here because of this skipping or dropping out of QRS, the cardiac output will be decreases and patient may go into hypotension and syncopic attack. So that should be treated by dopamine, and atropine is given to increases the heart rate, and a pacemaker to correct the abnormal rhythm into the normal sinus rhythm. See, this is the second morbits, that is two P waves will be the here that QRS complex is being skipped. So like the 2-3 P waves will be followed and one QRS complex. So that is morbits 2. And third degree heart block, it is complete heart block. There is a total dissociation between atria and ventricles. So here the atrial impulses are not at all being transmitted or conducted to the ventricles. The atrial and ventricular contractions are not related to each other. That is 2:1 or 3:1 ratio. That too there is distorted P wave, and QRS will be different, and a P wave will be dissociation. There is no connection between the P wave as well as the QRS. Atrial will contract and ventricle will contract in a dissociative manner. And the causes are cardiac diseases, systemic diseases can cause, and some of the medications also. And manifestations, patient will be over fatigability, hypotension, syncopic attack, and heart failure. Treatment, atropine, isoproterenol, and dopamine. And next one is ventricular dysrhythmias. Ventricular dysrhythmias, first one is premature ventricular contractions. PVC, it is a contraction coming from an ectopic focus in the ventricles. It is a premature occurrence of a QRS complex, like a premature atrial contraction we studied. So like that, premature ventricular contraction. Here PVC, the QRS, the PVC QRS complex, the duration will be more than 0.12 second, and it is distorted in shape and compared with normal QRS complex. See here that reading rounded shape, it is PVC QRS and premature QRS complex. Why this premature occurs? Before the normal origin, the ectopic origin of electric impulses takes place. So premature ventricular contraction occurs. See here there are two PVCs can occur, that is multifocal PVCs, and another one is unifocal PVCs. When we observe the ECG strip, immediately we must able to identify whether it is a multifocal or unifocal PVC. First one is multifocal. See here multifocal, the PVCs are different in shape. Every PVCs like see, this one is entirely different, and this is the normal one, and this abnormal PVCs, and this abnormal PVC is different. So the PVC complex will be different. Why this multifocal PVC is showing different or distorted shape? Because this premature ventricular contraction originates from different ectopic foci. And in unifocal PVCs, here a single ectopic foci. From single ectopic, the origination will be developed. So the PVCs are uniform in shape and pattern in unifocal PVC. That is the major difference between multifocal and unifocal. In unifocal, the PVCs will show same shape and duration and pattern as it originates from the single ectopic foci. But in multifocal PVC, here the PVC shows different shapes and pattern as it originates from different multiple ectopic foci. And another one is ventricular bigeminy. This is ventricular bigeminy. When there is every other beat is a PVC, then we say that is a ventricular bigeminy. See here, this is the normal QRS complex, and this is the PVC. This is normal QRS, this is PVC. So when we observe the every other beat is a PVC, then we say that is a ventricular bigeminy. And the third complex is a PVC, then we say that is a ventricular trigeminy. Every third beat is a PVC, that we say as a ventricular trigeminy. And when there is two consecutive PVCs observed here, then we say that as a couplets, ventricular couplets. See here, there is 2 consecutive PVCs. It is called ventricular couplets. And treatment, oxygen therapy for hypoxia and electrolyte replacement should be given. The common electrolytes which are responsible for this PVC or like a low potassium level, hypokalemia can become one of the reason, and hypercalcemia, when the calcium high calcium level in the blood, that will cause PVC, and hypomagnesemia also can cause. These are the common electrolytes which are responsible for PVC. So when you see that when you come to the part of treatment, these electrolytes, so the patient's clinical parameters should be observed, and the electrolytes imbalances should be, if it is observed in electrolyte imbalances, that should be replaced. And amiodarone anti-dysrhythmic medications. And next one is ventricular tachycardia. It is defined as 3 or more premature ventricular contractions in a row. We say that is a ventricular tachycardia. Like when we observe 2 consecutive PVCs, we called it as a ventricular couplets. If it is 3 or more premature ventricular contraction, we say that we give another name, that is ventricular tachycardia. It occurs when an ectopic foci or foci fire very rapidly or repeatedly. Monomorphic VT has QRS complex that are same shape or size, and polymorphic VT, that is a different shape, or the pattern of the QRS will be different, that we say torsates the pointers. When the QRS complex gradually change from one shape to size to another shape, we say that is a polymorphic or torsade the pointers. Here the rate of ventricular discharge would be 150 to 250 per minute. The etiology, increased myocardial irritability associated with coronary artery disease and coronary heart diseases like myocardial infarction and electrolyte imbalances, and the diseases of the myocardium, that is cardiomyopathy. Clinical significance or the symptoms: sustained VT causes decreased diastolic filling, leads to low cardiac output, hypotension, decreased cerebral blood flow, and even cardiopulmonary arrest also can occur. Treatment: if the patient is stable, like a monomorphic, that is if the QRS complex, the PVC observed regular, and then continuous monitoring should be done, and obtain 12-lead electrocardiogram, and IV procainamide and aminodarone anti-dysrhythmic drug should be given to convert the tachydysrhythmia into normal sinus rhythm. And if the patient is unstable, that is unconscious or without a proper bounding pulse, then it should be treated as a ventricular fibrillation. So immediately we must start CPR and immediate defibrillation, followed by vasopressors and amiodarone. Like ACLS procedure should be started immediately if we found unstable ventricular tachycardia. Unstable ventricular tachycardia must be treated like ventricular fibrillation only. So immediately ACLS should be started. See, this is ventricular tachycardia. Like this is monomorphic ventricular tachycardia. See here, there is the uniform pattern of PVC. Okay. Then one is ventricular fibrillation. It is a severe disorganized ventricular rhythm that results in ineffective quivering of the ventricles. So firing of multiple ectopic foci in the ventricle, and when compared to ventricular tachycardia, this is a severe disorganized ventricular rhythm that results in ineffective quivering. Here just we can observe the ventricles are just shaking. There is no effective contraction in the ventricles, just shaking, or that we say quivering of ventricles. So there is no effective contraction, so the cardiac output will not be produced from the heart, so it can be considered as a asystole, represents the total absence of ventricular contraction. And here no atrial activity will be seen in ECG, absence of audible heartbeat, palpable pulse, and respiration. So this we can consider as a asystolic stage. So immediately we could start this, like defibrillation should be given and ACLS. See, this is the exact ECG strip of ventricular fibrillation, just quivering or just shaking of the ventricle. There is no effective contraction, even atrial contraction also won't be there, and ventricular contraction also, so though no cardiac output will be produced from the heart. Same as ventricular tachycardia and untreated ventricular tachycardia may lead to ventricular fibrillation. Like initially patient may show ventricular tachycardia only in the ECG or in the monitors. If we neglect or if we didn't find or recognize as a ventricular tachycardia, that can be progressed into ventricular fibrillation. And treatment, immediate defibrillation should be given, and CPR with the initiation of ACLS, advanced cardiac life support, and eradicating the causes. And vasoactive and anti-arrhythmic medication should be given. And the common management. So hope you all understood the common dysrhythmias. I went very basically, like a deeply you can go through your text or library you can go for. And the common abnormalities, what are the common abnormalities or dysrhythmias I listed out? Ventricle dysrhythmias. The lethal dysrhythmias are ventricular fibrillation and ventricular tachycardia. And PVC also we have mentioned here. And next, adjunctive modalities and management for dysrhythmias. Here the treatment should be depends upon whether the dysrhythmia is acute or chronic, and based on the acute or chronic origin of the dysrhythmias, the treatment will be vary, and the cause of the dysrhythmias, because some of the causes are due to electrolyte imbalances and hypoxia or hypothermia or hypoendocrine states. These are the conditions are manageable by the root cause for the dysrhythmia should be ruled out, and that should be properly treated. Then the further progress of the dysrhythmias can be prevented. So the treatment part, before starting the definitive treatment, the dysrhythmia should be observed whether it is acute or chronic, and the cause of the dysrhythmia should be identified. And the ultimate one for bradycardia cases, pacemaker is the ultimate choice or definitive management we could say. So pacemaker, will see brief about the pacemaker. Pacemakers are the electrode devices that can be used to initiate the heartbeat when the heart's intrinsic electric system cannot effectively generate a rate adequate to support cardiac output. So pacemakers are the electrodes, like mainly pacemakers we are using for where there is when there is effective contraction or when the heart is not beating adequately, then we'll place pacemakers. And uses when a patient has a permanent or temporary slower than normal impulse formation, when a symptomatic AV of ventricular conduction disturbances to control some tachydysrhythmias that don't respond to medication. When the medications doesn't respond to the tachydysrhythmias, then we can give pacemaker also in order to give a supportive effect to correct the dysrhythmias. And components here, electronic pulse generator will be there, it contains the circuit, and batteries that determine the rate of electric stimulus. And there are three main parts, main components present in pacemaker. First one is electronic pulse generator, second one is pacemaker electrode, and third one is elective replacement indicator. Electronic pulse generator, that is there is a pulse generating machine will be kept under the skin in the subcutaneous pocket, and pacemaker electrodes which carry the impulses created by the generator to the heart. It contains two leads, endocardial as well as the epicardial verse will be there. And next one is electric replacement indicator, that is battery which gives a signal when it is approaching the depletion. See, this is the pacemaker which we implanted under the skin, and the leads here we see the leads which carries or which entered into the heart chambers, and from here the pacemaker generates the signals that carries through the leads into the heart, and that will correct or that will reduce the heart rate or correct the dysrhythmias. And the battery also will be kept in this packet only generator, pulse generating packet. The battery also will be kept. And there are two types of pacemaker. There are temporary pacemaker and a permanent pacemaker. Temporary pacemakers, we are using it for short-term use. During hospitalization, mainly we are using for 24 hours or for a short period of time until the permanent pacemaker take over the function, or sometimes after major cardiac surgeries, in order to give a proper, until the restoration of the function by the heart, patient will be kept in temporary pacemaker, and it is located outside the body and may be taped to the skin or attached to the belt, or sometimes it can be attached to the patient's bed also. The size of the temporary pacemaker is about size of a small paperback book. It is very small in size. And permanent pacemakers are the pacemaker that are intended for a long-term use. And here we are using endocardial leads. It should be, the lead should go inside the chambers, and a generator implanted in a subcutaneous pocket, and they last approximately for 6 to 12 years. That battery may get last for 6 to 12 years, and within that period, usually 6 months before that, battery will give a signal that the battery is going to deplete. So within 6 to 12 months of period, that battery should be replaced. And the permanent generator weighs less than 1 ounce and is the size of a thick credit card size. And complications of pacemaker use, it is very important in knowing healthcare workers, either medical or nursing people, must know the complications. We must teach to the patient who all implanted the pacemaker. Local infection is the most common one, and pneumothorax and hemothorax can occur, bleeding, hematoma formation, and ventricular ectopy and tachycardia from irritation of the ventricular wall by the endocardial electrodes. These endocardial electrodes we kept inside the chambers, so sometimes from the electrodes it may get irritation to the ventricular walls. So ectopic origin, already to correct the ectopic foci or tachydysrhythmias, we are keeping these pacemakers. As a complication of this pacemaker electrodes also, the patient can develop some dysrhythmias. A movement or dislocation of the lead can occur, that is manipulation of the manipulation or extra work which given to that hand or extremities, that battery may get the pulse generating pacemaker may get dislocated, or sometimes the endocardial leads may get dislocated. And phrenic nerve or diaphragmatic or skeletal muscle stimulation if the lead is dislocated or if the delivered energy is set high. Sometimes due to the dislocation of lead, it can lead to damages to the or extra overstimulation to these surrounding structures. Cardiac perforation can occur. It can result in pericardial effusion, rarely cardiac tamponade. So due to pericardial effusion, it may compress the heart. That will result in because of extra pressure which surrounding the heart may result in cardiac tamponade also, which may occur at the time of implantation or immediate complication, or sometimes the patient can develop it as a later also. Cardiac perforation. Twiddler syndrome, that is a a manipulation by the patient, like the pulse this because of this over exercise or over exertion on the hand, or patient may do some intentionally or non-intentionally vigorous activity, so the pacemaker may get manipulated, so that lead to Twiddler syndrome. And pacemaker syndrome, hemodynamic instability caused by ventricular pacing, or sometimes due to loss of AV synchrony with the pacemaker supply, and the original electric impulses which develops from the heart may get synchrony and may develop pacemaker syndrome. And when you see the nursing care aspect, The battery and security of connections of temporary pacemaker shall be checked every shift, and it should be documented in the patient's medical record. And ECG should be monitored very carefully to detect pacemaker malfunction, because in complication we have mentioned that a pacemaker malfunction that may lead to ectopic origin of electric fire from the ventricles, because this leads, endocardial leads may cause irritation to the ventricular wall, may cause ectopic foci. So the ECG should be monitored very carefully to detect any pacemaker malfunction. Monitor vital signs, especially heart rate, because the patient experiencing pacemaker malfunction may develop bradycardia. After implanted the pacemaker, nurses should minimizing patient activity to prevent dislodgement of the patient electrodes. And how to prevent the complications? Because lots of complication the patient could develop as a whether immediate complication or sometimes after some period of pacemaker implantation. So the complication must be prevented. It is in the hand of the healthcare workers. So the proper prevention and the complication should be avoided. So prophylactic antibiotic must be given to the patient, and antibiotic irrigation of the subcutaneous pocket prior to the generator placement has decreased the rate of infection to less than 2%, because this local infection or sometimes systemic infection also can be possible if the pacemaker implantation process is not followed by a proper aseptic technique. So to avoid the occurrence of complications, antibiotic irrigation of the subcutaneous pocket prior to the generator placement. And if bleeding or hematoma occur, use of cold compressors, and the site is carefully inspected for purulent drainage, erythema, edema. These are all the symptoms of local infection, as well as for systemic infection the patient should be observed for. And frequent ECG monitoring to detect cardiac perforation, because this condition can be recognized by the change in QRS complex morphology. And symptoms of perforation that include pleuritic chest pain from the pericarditis and diaphragmatic or intercostal muscle stimulation. So if the patient says some unusual pleuritic chest pain, so the healthcare workers, either medical or nurses, must have the recognition that might be due to the symptom of perforation, because cardiac perforation become one of the complication of pacemaker implantation. So this should be immediately notified, and the treatment should be taken properly. And patient education is very much important part after the pacemaker implantation. So patient education is much more better to avoid these complications. So we need to advise the patient to place digital cellular phones at least 6 to 12 inches away from the pacemaker generator, or not to carry them in a shirt pocket. And patient should be cautioned to avoid such situation to simply move farther away from the area if they experience dizziness or a feeling of rapid or irregular heartbeat. And tell the patient that for the first few weeks after receiving the pacemaker, don't raise the arm where the pacemaker implanted, that closer arm should not be moved further. And keeping the arm down will help the area heal and keep the leads from moving. And immediately after pacemaker, the bathing should be avoided. After third day from the procedure, the patient can take the bath, and incision site should be gently washed, and any lotion or powders are not necessary to place over there. And arm exercise should not be done immediately after pacemaker, and vigorous activity should be avoided, and the mild activity can be carried out. And for 1 to 2 months, don't lift, push or pull anything that weighs more than 2.3 kg, including children. And signs of pacemaker malfunction to report, including dizziness, fainting, fatigue, weakness, chest pain or palpitation. These are the common symptoms which develops as a result of pacemaker malfunction. So we must teach to the patients that once the patient develops such following symptoms, they have to report to the concerned department and to proceed further. And tight fitting dresses should be avoided, etc. Next, cardioversion or defibrillation. So this both defibrillation is the choice to end ventricular fibrillation or pulseless ventricular tachycardia. The main difference between defibrillation and cardioversion: defibrillation is a emergency procedure. Emergency or the urgent basis we do defibrillation. Cardioversion is a planned one. And the main difference between cardioversion and defibrillation is the two common differences. One thing is timing of the timing and circumstances. Timing of the delivery of the joules, and the next one is circumstances. At what time we should do the procedure. Defibrillation, that is a emergency case. Emergency, that is ventricular fibrillation or pulseless ventricular tachycardia, if you observed in the ECG, immediately, irrespective of any other thing, defibrillation must be started. And cardioversion, that is a wait and watch procedure that we can start even after like some period of time, like after treating with medication or other procedures, then cardioversion procedure can be given to correct the dysrhythmias. And types, internal defibrillators are there and automated external defibrillators. Internal defibrillators are they are implanted directly in the user of the devices, so it is called the implantable cardioverter defibrillator, and this type of defibrillator is designed to provide immediate defibrillation to high risk patients. In automated external defibrillator, it is mainly used in hospitals and ambulance, but are increasingly common in outside the medical areas, and we could see AEDs in malls and big shops also, like to provide or as a emergency treatment. We are using these AEDs in outside hospital also. And placement of electrodes, it can be like it is monophasic defibrillators are there and biphasic defibrillators. Monophasic defibrillators are there, that joules are the currents will be flow in one direction. In biphasic defibrillators, in both direction, in opposite direction, the electric joules will flow. And placement of electrolytes is sternoapical method and anterior posterior method we can keep, and the commonest we use here is sternoapical method. The one paddle should be placed in the right of the chest just below the clavicle, and the second one is the left side just over the left pectoral muscle under the breast or in the apical region just near to the fifth intercostal space or that mid clavicular line, that apical pulse where we feel, over that the second paddle should be placed. And already I have mentioned the difference between cardioversion and defibrillation. And steps: CPR should be in progress until the defibrillation is available. So when you observe VTAC or ventricular fibrillation in the ECG, immediately we must start defibrillation, but it may take some time to reach the defibrillation to the patient's side. So by the time, CPR should be in continuously progress. And once the defibrillator reached, turn the defibrillator on and select the proper energy level and check to see synchronizer switch is turned off. When you give cardioversion, the synchronizer switch should be switched on. When we give defibrillation, the synchronizer switch should be turned off. It should be make sure before administer defibrillation. Apply conducive material to the chest. Charge the defibrillator using the button on the defibrillator or the paddles. Position the paddles. Call and look to see that everyone is all clear. There is no one is touching or near to the patient cot or a patient. To ensure that personnel are not touching patient or cot, deliver the charge by depressing the buttons on both paddles simultaneously. The recommended energy for initial shock: if you provide biphasic deliver, the initial is 120 to 200 joules. If we provide monophasic deliver, initial shock is 360 joules. Cardioversion, synchronized cardioversion, we can say it is the therapy of choice for the patient with ventricular tachyarrhythmias. Synchronizes circuit in the defibrillator, delivers a shock that is programmed to occur on the R wave of the QRS complex. And when you provide a synchronized cardioversion, the defibrillator, the switch should be turned on when cardioversion is planned. The initial energy which we provide in synchronized cardioversion is 50 to 100 joules in biphasic and 100 joules in monophasic. But in defibrillator, 120 to 200 joules in biphasic and in monophasic 360 joules. And preparation for the patient, anticoagulation should be given few weeks prior to the procedure. If we do the cardioversion as an elective, digoxin should be withheld for 48 hours, NPO for at least 8 hours, and intravenous sedation and oxygenation should be given. And post-procedure care, airway pattern should be maintained and proper clinical parameters should be observed in either vital signs and the oxygen saturation also. And the patient should be continuously connected with the 12-lead ECG monitor. And when you see the medication part, antiarrhythmic medications, there are 5 different classes of antiarrhythmic medication. Sodium channel blockers, example quinidine, procainamide, and lidocaine and encanamide, and different based on the different function, like some medication procainamide, sometimes it slows the conduction but prolong the resting stage repolarization, and lidocaine slow the conduction and repolarization stage also will be shortened. So accordingly, the dysrhythmia type, the sodium channel blockers will be selected, procainamide, lidocaine and encanamide. Second class is beta blockers. It decreases the conduction velocity. So as I said earlier, the cardiac cells have 4 main properties: automaticity, excitability, conductivity and contractibility. 4 properties. So these beta blockers, the conducting capacity that will be reduced, and also automaticity also will be decreases, and slow impulses conduction in AV node. Example, propranolol and acebutolol can be given as a beta blockers. And class 3 medications, prolonged repolarization, amiodarone. This also comes under anti-dysrhythmic medications. When any other medications are not effective, then as a emergency anti-arrhythmic medication, amiodarone will be given. Class 4 group of medication, calcium channel blockers. It blocks the calcium influx and decreases the excitability and contractibility of the myocardial cardiac muscles. Cardiac